We're delighted again to be with infectious disease expert Debbie Gold, who has been a hospital epidemiologist for more than 30 years at Kaiser. She has given since the beginning of the pandemic, she's given over 80 presentations with a project called the MAVEN Project, which is updating medical workers across the country about the latest research and safe practices around COVID. Our talks with Debbie happen once a quarter, and I can't say enough, Debbie, to thank you for being with us on such a regular basis and answering the questions that have come in from the OLLI members, and frankly, have also come in because of today's Washington Post and New York Times articles, causing a lot of questions to emerge, which we're going to ask you. So Debbie, in opening, we met, I think it was two months ago. You and I just agreed that we won't schedule another briefing until we know that it is necessary. So let's just, why don't you start with, are we more hopeful at this moment as we go forward? And then I'll start to ask you more particular questions.
Yes and no. I would say we have a lot of people vaccinated now, especially in the Bay Area. We have just withstood the Omicron onslaught. So a lot of people got infected, even whether or not they were vaccinated. And so we have a lot of immune people vaccinated or who got boosted by an Omicron infection, or unvaccinated who got maybe some protection because they had a natural infection. So in that sense, I think we have a population, at least locally, that is probably not at herd immunity. We could still see some transmission in communities where vaccination rates are low. But I think that we're moving into a time when we're going to see transmission, but it will be at a low level, and we will not have excessive burden on the healthcare system. Hospitalizations won't be a problem. ICU beds won't be a problem. We have really, and staffing hopefully in hospitals won't be a problem, so that people will get good care if they do get into the hospital, and the death rates will remain low. And I think that we could be in a situation like that for a while now. It is also possible that we might see a new variant emerge. We already know that BA.2, which is an Omicron subvariant, is circulating. It is more transmissible than regular Omicron. It's unclear whether it is more virulent, but we could see that, or another variant that has a greater ability to evade the immune response to vaccine or monoclonal antibodies, and then we'll be in trouble again. So everything, everything has to be couched in uncertain terms, because we don't really know it's coming.
Well, granted, how much we don't know, and knowing that there is the feeling that it's about to be springtime, and people are really just so eager to get out and be with each other. You may not know, Debbie, but we opened the doors at Freight and Salvage a month ago.
I know.
Yeah, so for 4 weeks, we've been bringing people back to Freight and Salvage. And we've had, a protocol of, it was 3 to 4 stations where people came in with their vaccination and booster records, and then their symptom screeners. And then we had to see, the university was requiring rapid tests or PCR tests 48 hours before they came in. And then I think it was and then the symptom screener of checking people's temperature. We've just learned from the university that they are going to not require the tests, the rapid tests, which we're very thankful for, because we think that that was discouraging to people. And the people who are coming into the freight seem to be feeling relatively safe with the protocols and with everybody wearing, you know, a really good N95 masks. We've all been checking. And so it does feel relatively safe. But now as we move forward, I want to just ask a couple of questions that came in from a member. Jane Nielsen had a question. She said, my condo association of 22 units would like to hold an outdoor open house. After 2 years of isolating, it's a chance to meet and greet neighbors, enjoy refreshments, and rebuild community. What protocols do we need to practice?
Well, I think the first is doing it outdoors. I think that that's certainly the safest. I think that it would be nice to know that everybody was vaccinated and boosted. You might not be able to ask people if they are, but if you can, it would be safest if everyone were vaccinated and boosted. And if you want to add another layer of safety, depending on how big the space is outdoors, how close people are going to be to each other, because you're eating and drinking, obviously, it's an open house, so people will not be wearing masks. You could have people test earlier in the day that they're, the day of the event. And, that's a bunch of different layers. But I think the most important one is doing it outside.
Okay, then we've got an indoor question. There is still some fear that as people enter unventilated spaces in public or private buildings, go into an elevator or go into a hallway, that if in fact there has been an unvaccinated person who has COVID, you enter those spaces. Are those threatening? How to consider those?
So I think it is possible to step into an elevator where somebody with COVID who is unvaccinated, not masked, because of course you don't need to mask now, might have been coughing in that elevator. And if you step in right after they step out, you might be exposed. And so I think that especially if you are over 65 or have medical conditions that would make it unlikely that you would mount a robust response to vaccine, or you had your booster a long time ago, like 6 months ago, or last summer, it might make sense to wear a mask when you are in public places, indoors, where you really don't know anything about the number of air exchanges that are happening an hour, where there may be people unmasked and potentially infected. And, I'm wearing a mask indoors. I was at Trader Joe's this morning. There were 2 people in the store who were not masked, and they were both people who work at the store, because in San Francisco now, as of last Wednesday, the indoor masking is no longer required. So of course we're checking out, and my husband gets into the line of the checker who is not masked. Like, what are you doing? If you have a choice of 5 people who are masked and 1 person who isn't masked, why would you go in the line of the person who's not masked? She's probably also not vaccinated. So why would you do that? I don't get it. Anyway, so I'm still wearing a mask indoors, and most people in San Francisco are also doing it.
And Debbie, that's my experience too, both in San Francisco and in Berkeley, that people are continuing to wear masks. Do you recommend that we all continue to do that for
indoors? And I have to say, I don't wear a mask outdoors. I go for a walk, I'm not wearing a mask. I go like to my neighborhood main street. If I go in to get a cup of coffee, I'm wearing a mask, but on the sidewalk, I'm not wearing a mask. So I don't go to busy time where I'm going to be encountering a lot of people, but I don't wear a mask outdoors.
Yeah, that's true for me too. It's such a freedom to be able to walk outside without a mask on. But do you imagine that wearing masks are now going to be with us for the foreseeable future? Would you recommend wearing them?
I watch the numbers every day, and I'm sort of waiting for the numbers to get down to a place where we were like in last August. But I think that wearing a mask for some people is going to be a permanent fixture. Especially people who are immunocompromised. And for the rest of us, I'm not really sure. I think probably for the foreseeable future, if and when I start traveling again, I hope to by the end of the year, I'm still going to be I'm in a mask on the plane and in the airport and all of that, even if that requirement goes away. I don't want to be stuck in a tube sitting next to a coughing person, and I don't know what they have. And so, and we don't know when the next, horrible thing is coming. So even if it's not COVID, it might be something else. So I think that I would have a low threshold to mask in situations where I could not distance and where I would have to sit for a long time, like, 14 hours. I don't want to be sitting next to a coughing person.
I know it was striking me this morning. I'm sitting in Tamim Ansari's course at Freight and Salvage. And, the first person next to me is about 50 feet away. And I thought, can I take my mask off? Partly because I know that they have a new ventilation system, the air is circulating 9 times an hour, et cetera, et cetera. But I thought, probably not. Keep that mask on, even if you're not close to others. Is that correct?
Although, 6 to 9 times an hour, that's good. That's like approaching a hospital. Hospitals
Right.
have to maintain 6 to 12 air exchanges an hour. So that's really good. If I were younger and did not have contact with vulnerable people, I might think about taking my mask off in a situation where I was way distanced and knew that the air exchanges were really excellent.
Yeah, good.
I might think of that, but again, I would be a younger person.
Okay, well, Debbie, thanks. Let's talk a bit about the efficacy of the third shot and what we know. And when does its effectiveness start to wane, and for whom? Can you give some guidelines on that?
Yeah, so the third shot, so there are some data. Now I'm thinking where, I think it was in the New England Journal. Anyway, it looks like antibody titers wane significantly after the third shot. So I'm talking about Pfizer, Moderna, after 5 months. So what does that mean clinically? It's really unclear what that means in the real world. But if you look at something more concrete, like hospitalizations and death, the protection that a third shot gives you against hospitalization and death is really still very good. It's like in 80 to 90%, even after 5 months. And there's some recent data to suggest that our T cell responses, the cellular part of the immune system, will persist for maybe years. But the T cells don't kick in right away. It's the antibodies that will kick in right away when you get exposed. And so it is that part of the immune system, that rapid fire part of the immune system, that we're most interested in for being able to handle the virus if you are exposed in very short order. So that's why people have been talking about 4th doses. Certainly people who are immunocompromised should take 4th doses. But for the rest of us, it's really unclear. And I have been waiting for data to come out of Israel. They have been giving 4th doses. First, they were giving it just to people over 65, healthcare workers and immunocompromised individuals, but now they're giving it fourth doses to everyone over 16 or 18, I think. And they should be producing some actionable data for us soon. I expected to see it before now, frankly, but I haven't seen it yet. And I think that other decisions about boosters have been made based on Israeli data. And I think probably the decision about fourth doses and when those will be offered and what kind, will it be Omicron specific? Will it be just the same old, or might be based on Israeli data also.
How soon do you think that's likely to be offered? We don't know.
You know, probably not until the fall, as what I've read, but I don't know what that's based on. I don't know what kind of criteria they're using to try to inform that decision.
Well, we've got, I'm just going to take two members that sent in questions. On one hand, Claire, who has lupus, thinks that she should get that fourth shot.
Mm-hmm.
Joan,
I would say lupus on treatment, so on steroids, on biologicals, on some kind of, there are a lot of women walking around with lupus who don't even know it and who don't really have symptoms, who it's, the diagnosis is made sort of accidentally looking for something else. And those people are probably not very immunocompromised. But if you have a diagnosis of lupus and you're on treatment for it, I'd be going to get a fourth one for sure. Okay.
And then on the other hand, Joan, who turned 81, said, I'm in good health. But should I be going in to get that fourth booster? What would be your advice to her?
I would say that we're gonna understand about fourth boost or fourth shots soon. And I think that there's not an urgency since the case numbers are going down every day. And so we're not really in the throes of a surge right now. We're really on the tail end. And I think it would be fine just to sit tight and wait another 2 or 3 weeks, because I'm sure we're going to be seeing something out of Israel to tell us about whether fourth doses are needed, in what populations, and what the timing of them should be.
Well,
I'd wait. If I were 81 and healthy, I'd just wait and see what comes up. And that's going to be in the New York Times. It's going to be in the Washington Post. Everybody is waiting with bated breath to hear about those data. So it'll be easy to get a handle on what they are.
Well, what I've been hearing from OLLI members is that they're really interested in doing some national and international travel, and as soon as May. And so you would recommend they wait for a few weeks, and then if they're starting to travel in mid-May, it's 3 weeks, right, that they recommend.
Oh, you mean about taking a shot,
a fourth dose?
Yeah. So, that's a really good question. I went for a walk with one of my neighbors who's going to Europe for a month in April. And she didn't ask me about a fourth dose. And I didn't even think of it. I might think about doing that. Say, I'd wait until 2 weeks before and see what the numbers look like. And if things seem not to be going in the right direction, and I was thinking, did I get trip insurance? Should I cancel? Or I'm going come hell or high water, I might think about taking a fourth shot, but it does take 2 weeks to get the full benefit of that. So I would not do it sooner than, I wouldn't do it later than 2 weeks. So.
Right. Well, and the other thing that was another set of questions about this international travel, or, a son with a girlfriend in Brazil, should she come here? Should he go there? I realize that there's not, that each country is different, has a different COVID reality. Each country has a different set of entrance requirements. And so what I am seeing is that Cal Discoveries, the UC Berkeley, Alumni Association, is opening up its international travel and I think it's starting in Europe in April and May, excuse me. And I think they have to suss all of that out for their travelers. So I see a benefit around organized travel like Cal Discovery, who helps you kind of negotiate all of those things around the COVID protocol. But who else? Is there another trusted source? Should we go to who else should we go to in government?
So the CDC, on their website, they have travel information for healthcare providers and for travelers. And once you navigate to that part of the CDC's website, you put in the country, the destination, and you will get, if there are State Department warnings about that destination. I haven't looked at it, to tell you the truth, during COVID at all, but it will tell you about malaria risk, Zika risk, hepatitis E risk, all kinds of risks, and whether there are vaccinations required, including yellow fever. And it's just a wealth of information about different destinations in the world. And I'm sure that they must have some kind of information about COVID and whether COVID testing is required. And if you can't get it on that website, then you might have to go to the government website of the destination and look for what the COVID testing requirements are. I think it should be mentioned that while we are on the downslope of Omicron, there are many places in the world, especially in the developing world, that are still on the upswing of Omicron. And there are places in the world that have never had COVID before that now have COVID. And so not everyone is in the same situation that we are right now in terms of case numbers declining. There are places where case numbers are rising exponentially.
Great. I know I read somewhere, Africa, for instance, 10%, of the continent is vaccinated.
Yeah, 11%. I think it's 11% of the continent. It's not uniform country to country. Certainly, I think South Africa is about 40% vaccinated, and then other countries have hardly any at all. But of the 11%, hardly any have had a booster. So, I think that something should be done imminently to remedy that problem. I know that mRNA vaccines are going to be produced in, 8 African countries, I think. But that's not going to be right away. And a lot of damage can be done while we're waiting for that to happen.
Yeah. Well, thank you, members, who Louise and Susan G, putting in that, State Department has good information, embassies have good information, so you can cull this on your own. And I know Marty's looking for that trip to Europe, and trying to figure out when to go to Western Europe. And so I think we've given him some guidelines on that. Is there, what does the threshold look like for when we go from our pandemic selves to our endemic selves? Or what does that look like? Are there signposts that we should be looking for?
I think it's gonna, well, first I should say we are not in an endemic phase right now. We have still too many cases, too much transmission, too many hospitalizations, not very many deaths, fortunately, but we are not in an endemic phase yet. We will move into that phase gradually, and it will be, the timeline will be different for different places. For example, places where vaccination rates are very low, like in the Midwest and the South, they will move into an endemic phase a lot later than we will, because our vaccination rates are high, and we're just doing a lot better overall. So how will we know what are going to be the signposts? I think people are going to be talking about it a lot. So you'll know because the director of public health for the state is going to say we're now entering an endemic phase, but that might only be in the north and not in the south, where there are a lot more infections. And certainly a lot of the rural counties in the south still have huge numbers of infections. So even in the state of California, which is obviously a huge state, the entry into the endemic phase is not going to be the same everywhere. But when hospitalizations are low and manageable, when people are still getting infected, but in numbers where contact tracing can be done and that contact tracing is not overwhelmed, where testing is plentiful and can be done, at the drop of a hat. I think that those are going to be the signs that we're getting into an endemic phase, and we'll be dealing with COVID-19 for the rest of our lives on some level once that happens. And we may be taking a booster every year, depending on what the circulating strains are.
Mm-hmm. One of the chat questions was wanting to return to that question of the variant, the Omicron variant BA.
BA.2.
BA2, yeah, BA.2. Can you say just a little bit more? Are people worried about it?
Yeah. So we know from Denmark, is that right? Yeah, Denmark, that BA.2 has a transmission advantage over BA.1, which is the Omicron that we've been dealing with. And as of a couple of weeks ago, BA.2 constituted 40% of isolates in Denmark. Interestingly, that was not true in Norway or Finland or Sweden, but in Denmark, it was the case. BA.2 has been spreading rapidly in the UK, and there is concern about its potential to cause another surge. It's unclear about if it is more virulent or if it can evade the immune system more than Omicron can. And those are still outstanding questions, but it is on the radar of the World Health Organization and most countries that are doing monitoring. So probably more to come about BA.2. I think that as of the last week or so, it's accounted for about just under 4% of isolates in the US. So not, if it's got a transmission advantage, it's not huge over regular Omicron.
You mentioned earlier too about T cells. And I think there's been some additional mention in the media about B and T cells, and that it takes, as you mentioned, T cells some time to generate in strength. Is there anything else to say here in this format about B and T cells?
Also with memory B cells and T cells. So I will say that our understanding of T cells is a lot less than our understanding of antibody. So the cellular immune side is much less understood and much less studied compared to this humoral immune side, which is measuring antibodies. And the reason for that is that the assays that are used to study T cells and their function are very labor intensive and very expensive to do. And so it's, there aren't that many labs that are set up to do it. There aren't commercial, well, there may be one commercial test that measures T cell function, but I'm not sure how good it is. And so we just know a lot less about T cell functioning because of the sort of limited amount of investigation that's been done. But Scripps in San Diego is one of the main centers for looking at this kind of thing, and Sean Crotty's lab. I think that's the name of the guy. He's sort of the main T-cell guy. And he's funded to do it, but they're limited labs. And so the amount of data coming out is limited too.
Okay, looks like we've got a couple more questions about the infectiousness of Omicron, and saying the question from Mary: a vaccinated person who has Omicron can be just as infectious as a non-vaccinated person, correct? Yes. My son-in-law and niece, both vaccinated and boosted, contracted the virus just living a normal life, working from home and being cautious when outside the home.
Yeah. So the infection. So my husband's asking me the other day, what about within 6 feet for 15 minutes? That's considered a significant exposure, right? If you're within less than 6 feet for 15 minutes without, without a mask. But, and that definition for significant exposure has not changed. However, because of the dramatic increase in transmissibility of Omicron, I'm not sure that it applies, and that it might be possible to get an exposure. If the infectious dose is very low, it might be possible to get an exposure under under 15 minutes. More than 6 feet away. It's hard to say, because of course it's not an easy thing to study. So I think that's how people get infected, being careful. They think that they're careful sitting in the backyard chatting with their friend, having a cup of coffee, and then the friend gets COVID that night, and then they get COVID too, and you thought it was a safe encounter, but it really wasn't.
Right.
So.
And so Susan's question about the high school reunion, which is indoors, even though everybody's vaccinated, few people will be wearing masks. That's a high risk venture.
I think so. I think an indoor gathering where people are eating and drinking, so by definition are not wearing a mask. I think, and I think that that's a riskier situation, and certainly people who are vulnerable or live with people who are vulnerable probably should avoid situations like that. But people, it's just sort of depends on what your risk tolerance is, and people can who can tolerate more risk could go to something like that, but they just have to understand that it's not without risk.
Kathy,
the risk is, and I'll just say what the risk is. So the risk is that you would infect somebody who is vulnerable, even though you yourself might not get sick. And the risk is that you might develop long COVID, even though you might not get sick, or you might not get any symptoms at all and still develop long COVID. And that, would not be a good thing.
We have been talking about in other conversations about when to take the rapid test after we may have been in a more compromised situation, like an airline flight that's 3 hours, as Kathy has suggested. When should that test be taken? Is that a day after a flight? What do you think?
I would say day 3 to 5 would be the best time to do it. Mm-hmm.
And does that mean that you stay away from loved ones for that 3 to 5 days?
Yes, if they're vulnerable, like little kids, you would not, under 5s, you would not want to expose them if you had become infected on an airplane or whatever. Or people who are very elderly who would not be expected to mount a robust immune response to vaccine. You should wait that period of time before. Again, if you don't care, it doesn't matter. But if you're concerned, then that would be a good time not to be around people who, especially those who would be vulnerable to infection.
I'm eager to get to the questions around long haulers, but I see that there's still a couple of other questions that might be good to touch on. One is with a 2-year-old, the risk that they might present to a fully vaxxed grandma.
Oh, so I think that the risk is in the other direction.
Mm,
So if the grandma's healthy and fully vaccinated and boosted, then that grandma is pretty protected, but she might transmit infection to the 2-year-old who's not vaccinated. And most kids do fine. Most kids have very mild infection, but a few of them have horrible infection and develop the multi-system inflammatory disease of children. And I think there have been 8,000 deaths in the United States. I'm pretty sure that's right, since the beginning of the pandemic. So there are some kids who do very poorly, and it's hard to predict who those kids are. So I would be careful about transmission from the grandma to the 2-year-old. And one thing about this multi-system inflammatory disease of children, at least the early data from the UK suggested that kids of color were more susceptible than Caucasian kids. And I would be more worried about that. I haven't been paying a lot of attention to the pediatric literature, but I do definitely remember those early cases from the UK. They were all in, almost all of them were in kids of color.
Mm-hmm. Okay. There's a flood of more questions, but what I want to do is I'll come back to your questions, people that you're asking, but Debbie, let's focus now on the long haul and the long haulers with COVID, partly because if any of us picked up a Washington Post or New York Times today, there were fairly significant articles that were being published. And if you haven't read those, I strongly urge you to look at the Washington Post article, which is about, and I can't now myself bring it up, but let me mention the New York, oh, here it is, the Washington Post article, 5 months post-COVID, Nicole Murphy's heart rate is still doing strange things. And so it talks a lot about the cardiovascular symptoms. And then the New York Times has how long COVID exhausts the body. And then the other article is about exercise. And then there's a third article that talks about the cross-species infection rates, and more likely that we infect these other mammals, but that there has been some crossover there. So let's start with how do we distinguish between a body that's healing from COVID versus a longer new pathological problem that we're calling long COVID? Is there any way to know?
So long COVID is defined as symptoms associated with COVID that persist more than 4 weeks. So that's been the standard definition. And sometimes people who had acute COVID and appear to get over it will start to develop new symptoms beyond 4 weeks that they didn't have initially. And that might also be considered long COVID if there's no logical other explanation. So people who have long-term symptoms actually do need to get those worked up to exclude other potential conditions that might be causing those, because you wouldn't want to assign somebody a diagnosis of long COVID because of A, B, and C when it's actually hyperthyroidism or some other, kind of diagnosis that hasn't been established and is treatable. So people who have long COVID actually do need to see somebody to get evaluated and to make sure that nothing else is going on, and also to establish a rapport with a provider who's going to be able to, tough it out with them over a period that may last many months or even longer, because we don't really know about the trajectory yet of long COVID. When I was a fellow, so that was when I was doing my infectious disease training, I did a study on chronic fatigue syndrome. And that, we had to establish a chronic fatigue syndrome clinic, which, God, working in there. Well, I have to say, okay, so, and it was in that context that I started to understand about the exhaustion after minimal exercise business. And I had this shtick that I could just roll out right now about what I used to tell those patients. And here I am reading about it in the New York Times. And I'm like, I know all about this, just doing a very little bit of physical activity and then not being able to get out of bed the next day. I totally know about this. It's something that I've seen before. And actually long COVID is something I've seen before. We just didn't know what virus it was that was triggering it. But long COVID is basically chronic fatigue syndrome or some variant of that. I'm getting away from the question. I forget what the question was.
But that is touching upon it. I think that the folks who have suffered from chronic fatigue syndrome and have been told that it's psychosomatic now have others who, have too often been treated the same way now. Because of the lack of understanding.
Yep. And I also thought this, it's not a real thing, but you know what? Now it was a real thing. And those people probably had a viral infection that triggered this whole thing. And it is so clear. The association between COVID-19 and long COVID is so clear. So it's been, but unfortunately, those people, I think a subsegment of those people really didn't have chronic fatigue syndrome. They really did have a somatization disorder, but there are people who really did have chronic fatigue syndrome. And I'm sure it was the consequence of having had an antecedent viral infection.
Well, a Berkeley author, Dorothy Wall, has written the definitive book on the experiences of having chronic fatigue. And it's called Encounters with the Invisible. And I think a lot of these symptoms, are sort of are seeming to be invisible. They go in, as both of these articles are attesting to. People go in and they do CT scans and they do blood tests and they do X-rays, and it's sort of like, well, it looks normal, but they're not.
Right. The symptoms are totally real. The symptoms are real, but we can't really explain why they're there. There are many potential reasons why they might be there after a viral infection, but it's just very difficult to pin down why they're there and what to do about them and how long they're going to last. But there's more and more data coming out now about long COVID and the consequences of having COVID that are not exactly long COVID, but we now know from a very large study that was done in the VA system that people who have had acute COVID are at increased risk for all kinds of cardiovascular complications in the year after they recover from COVID. So it could be a stroke, a TIA, congestive heart failure, cardiac arrhythmias, you name it. You name the cardiac complication and the risk is increased maybe 2 times or between 1 and 2 times those compared to a population that didn't have COVID. So, and we're talking about, they looked at millions of people in the control group. So the risks of new diagnoses, and now particularly cardiovascular diagnoses, is real in the 12 months after recovery from COVID. So even though you don't have long COVID, you still have increased risks of other adverse outcomes.
Mm-hmm. Well, and we know that distance between, what gets researched and then what happens in the clinical environment. There's a big gap there. And it's again, kind of back to trusted sources, having a good relationship, with your doctor. I know I've talked to a number of people that are long haulers and their doctors just say, you got to live with it. That doesn't seem like.
Yeah. So, there are centers that are studying people who have long COVID, and one of them is at UCSF, and people can refer themselves. If you Google long COVID UCSF, you'll come up with the site. I can't remember what the abbreviations are, but there's a form where I think you can self-refer. And it's going to take a village to take care of these people, because the symptoms that they have can be protean and involve lots of different organ systems, and therefore would need to involve a neurologist, a physical therapist, just all kinds of different gastroenterologists, different subspecialties, pulmonologists, to take care of them, because there are symptomatic treatments that can be offered to people with long COVID while they're getting over it.
Yeah, and I think you and I talked before we went live about the PM&R website that was saying that between 30 and 60% of people who've contracted COVID have long-term symptoms.
Yeah, I mean, I just saw that on their website and I thought, I never saw any data that would suggest that that's true. And I don't think it is.
Okay.
Yeah, no, I think that's not right. But I don't know what percentage of people have long COVID. I will say, though, that having done this study over a period of over 2 years on chronic fatigue syndrome, I don't want to get within 100 miles of that diagnosis. I do not want to have that. It is life altering. And yeah, I just absolutely, and it's one of the main reasons I don't want to get even a breakthrough infection, because I'm vaccinated and boosted, but we know that people who are vaccinated and boosted can still get long COVID. And it isn't clear how much the risk is decreased. The UK just published a meta-analysis. It's their governmental COVID panel of experts just looked at all the data about long COVID and people who have been vaccinated. And I have flagged that report, but I haven't read it yet because I'm not giving a talk this week, but I will read it next week. The data that I've seen in several studies have shown that vaccination provides no protection. Vaccination provides 50% protection against development of long COVID. Vaccination produces 13% protection. So it's sort of all over the place. And I think maybe we are in need of a meta-analysis to understand that better, or better designed studies, because a lot of these are online surveys that people fill out or apps where people answer short questionnaires, and there are a lot of inherent biases in those kinds of studies.
Matt Shears, OLLI's curriculum coordinator, asks the following question about the long haul. Are there any studies being done on the long-term effects of COVID in children? Or more specifically, is there evidence to suggest that children may be prone to long COVID? And if so, how do those effects manifest? And what is the prognosis for a full recovery?
Okay, those are really very good questions. I can't really answer them, again, because I don't really follow the pediatric literature on this. I guess it's just because I'm not a pediatrician and my children are adults. So I don't have I just don't focus on that. I have read about anecdotal reports of kids developing long COVID, so it definitely can happen. I think it probably doesn't happen as frequently as it happens in adults. And so I don't know what the trajectory of their resolution of symptoms are And I don't even know what the sort of panoply of symptoms that kids get, or even how, yeah, I really don't know. Sorry.
Well, this leads me to a question, since part of my background is around advocacy and moving public policy to address the, different kinds of issues. I mean, is it possible that UCSF or Kaiser might investigate this from a pediatric point of view?
I don't know. I don't know about the study that's being done on long COVID. I think that's 18 and over. I haven't looked at that referral form in a long time, but I'm pretty sure it was adults. However, it is possible that investigators at UCSF or Stanford are looking into this. Certainly there are investigators at Stanford who sit on the FDA's advisory panel for consideration of vaccines in both adults and children. Yvonne Maldonado's on the news all the time. And so I guess I would be surprised if they weren't looking at at this in kids, but I don't know of any specific studies that are ongoing, at least around here.
Okay. All right. Well, thank you for that. Let's move on to the CDC. We've talked about the CDC in past conversations, and there's been an interesting review of how the CDC has managed, the whole pandemic. We understand they're prepping to come out with new guidelines, but there's been a kind of series of charges that they continue to withhold information, that they're not tracking breakthroughs, and even the criticism that they are overly reliant on Israel. So can you answer, what do you think?
So, I don't know, because I'm on the consumer end of the data coming out, and what they're holding back. I just can't imagine. I had read that they held back information about 18 to 49-year-olds and the helpfulness of boosters in that age group. I didn't even notice that I hadn't seen data for that age group. So, but now that I think about it, I'm thinking about the dashboard, and, you can generate all of these great graphics about protectiveness or vaccine effectiveness in 50 to 64-year-olds and over 65-year-olds, but not under 50. So that now kind of makes sense. Why didn't they release the data if they have it for 18 to 49-year-olds? That's a huge chunk of people in this country. I know that in the beginning, when breakthrough infections were first identified, the CDC said that the data that they have on breakthrough infections is dependent on the data that they get from the states. And some states were monitoring for breakthrough infection and collecting data about it, and some states were not monitoring it at all. So they got zero data from some states and lots of data from other states. And so I guess maybe they thought that the data that they did have was not representative of the general population and held it back. It's really hard to imagine why they would not release information about breakthrough infections and more information about who is developing them and why they're being developed. And, we just didn't get very much information. And maybe they should have mandated that state health departments collect and report that kind of information to them. But maybe even if they did that, directors of public health in red states are not being allowed to, or are now people who are not going to cooperate with the CDC or perform the function that they ordinarily would, because people who would do those jobs have been replaced with people who have no intention of doing those kinds of jobs. And so maybe it wouldn't even work in such a politicized society. Maybe, red states would have no intention of collecting that data and reporting it to the CDC. I don't know.
so we all are having to we have our own filters then around understanding what we're reading from the CTC and knowing, that some of those realities. As we're kind of nearing the hour, let me just return to a couple of questions that we asked earlier. Some believe that they had heard that you're not infectious immediately. So if you get infected on a flight, that it would take, some time after the flight. Some had believed it was a day or so after a flight, so that you would be okay saying hello to family and then quarantining. Is that a correct assumption?
There is an incubation period, and that would depend on the amount of virus that you got infected with. So if you got a big slug, your incubation period might be pretty short. And I don't know. I would a day, like when you got off the plane, could you go in the car with them to your hotel or home or whatever? I don't know. I probably wouldn't do that, but it just depends on what your risk tolerance is. Yeah, there's an incubation period during which you would not be, you wouldn't have enough virus to transmit to somebody else. But don't depend on the development of symptoms to know if you're infectious or not, because certainly you would be infectious at least a day before the onset of symptoms, if in fact you're going to develop symptoms.
Then a personal question to you, Debbie. I take it that you're not going to be taking any 6 or 12-hour flight across the country.
I might at the end of the year. I might at the end of the year. It's sort of, and I said the same thing last year. Oh, at the end, maybe in December I'll go. But I would be taking I would anticipate taking a very long flight. Yeah.
And this will be the final question. The grandmother with the 2-year-old, and you said it's more likely the grandmother would be giving the virus to the 2-year-old. What would you suggest to the grandmother how she could most protect the 2-year-old?
Oh, she could wear a mask, be with the 2-year-old outside, and the grandma could wear a mask. If the grandma doesn't go out much and it isn't really around a lot of people and is mostly sequestering at home, maybe not even a mask, but I think having interaction outside is the safest.
Great. Okay. Well, there's, thank you everybody for, posing your questions before we had this session with Debbie. And Debbie, there's a dozen more questions coming in. And so I'll go through those, but I think if you all have heard Debbie today and in past sessions, you know her to be a very cautious person, that her risk factor is usually a good rule of thumb, and that to take that under guidance. And then also, I think that I think the long haul, I think now is the thing that is concerning people. And I think there is at this point so little information. And so I think you're back to your warning, don't get it. Period. So Debbie, any closing remarks you want to make?
I would just say, stay tuned. Maybe things are going to start to be more hopeful. I'm hoping that we're going to be more hopeful. But I would say, don't throw away your mask, don't throw away your N95s, even though there is no more indoor masking mandate now. I think that we might have to return depending on what's going to happen. And I think that's all I can say.
Well, listen, thank you once again. I think this is about our 9th time to talk about COVID. And we'll keep our fingers crossed that maybe we can go longer before the next COVID update. But thank you. And Debbie, I'm really glad you'll be teaching the spring course on infectious diseases. I think it'll be a wonderful course. You've taught it before. And I know you have a section that's devoted to COVID. And you and I talked earlier that there are some ways in which we've dealt with pandemics in the past, or what we've learned from former pandemics that help us better understand our own trajectory with COVID-19. So thanks again.
You're welcome.
All right. See everybody in the classroom. The spring term, as you know, starts March 28th. And this week, also stay tuned. We're trying to see if we can bring Berkeley faculty to the fore for a conversation about Ukraine and Putin for this Friday. And so make sure that you're looking at your OLLI communications. All right, enough for now. Thank you, everybody, for coming.